that are being offered tonight: Kung Fu Panda, which is probably the one most of you will choose to go to, or Fall Guy, whatever that is. The movies start between 6 and 7 this evening, and you can get more details out at the front desk. Tomorrow night is the Ogden Regional Medical Center dinner starting at 6:30, and that is always the event where we honor our current president, and we will be having the opportunity to celebrate Kirsten's very valiant work this year. The Scott Andrews stage show of mystery, mind reading, and metaphor will take place. And then Friday night is the Holy Cross support, and that is from Davis and Tanner Clinic as well, and that's the family night at Sequest at the Layton Mall. And if you haven't had your fingers cleaned by the little fish, you'll want to go and experience that, along with getting to touch other creatures, including the bird section, which is quite entertaining. So I saw Dr. James come in. We're a couple minutes early. Are you okay to get started? So growing up, I thought my dad was the smartest man I ever met. And I continued to think that for much of my life until I had the opportunity to begin a friendship and learn at the feet of Dr. James. And I think Dad is now number 2. So it's a privilege to introduce a longtime friend and mentor, an incredible physician and educator, Dr. James.
Thank you, and all I can say is you're much too kind. I see a lot of old friends here, so many of you probably heard me before. It's a hard audience, you know. I have to think of something relatively new or entertaining to say to a group like this. What I really hope to do today is cover 3 topics. There we go. Number 1. I think we need to have a discussion about how we find care-associated injury events, something we all have some level of concern about, and I wanted to introduce the topic at that level. In the last few years, there's been a body of new research, and it turns out that this is a much larger problem than we had initially anticipated. So I want to just take you through the evidence around that and give you some sense of the scope and frame of it. I want to tie it next into the idea of healthcare costs. That's always topical, but particularly so at the present day. These sorts of injuries directly drive cost. And I thought to do so by showing you a little case study out of Common Spirit Health System, which is now working within this state as well. Number 3, we really ought to have a conversation about how you actually reduce injury rates. If there were a theme to this one, I want to get you to stop calling them errors. Thinking of them as errors, human errors, is the wrong way to approach it. Well, we'll see when we get to that, but that's what I thought to do today, and hopefully some new things that you haven't seen before perhaps, some new ideas, and, well, frankly, better ways of achieving our shared professional goals. So number 1, injury detection. You're all familiar with the old saying, primum non nocere. It's often attributed to people like Hippocrates or Galen. Actually, it first emerged in 1860, roughly. A couple of British physicians started to use the phrase. First, do no harm. The basic idea that when a patient comes into a healthcare delivery system, their least concern should be that somehow what we do will harm them, perhaps even more than their underlying disease. It's a shared commitment. It goes all the way to the bone in any good clinician. We all live it every day. I don't know about you, but I have a few skeletons in my closet. Oh, wait a minute. I do kind of know about you. I don't think there's a person alive that's practiced medicine for any length of time that hasn't had one of these haunt their past along the way. Well, its source. These days we have a long list of wonderfully effective interventions and treatments that we make available to the people who seek our help in their hour of need. The trouble is that anything that's powerful enough to heal can also harm. The tools we use are innately and inherently dangerous by their very nature. I found this great little meme on the internet. I really like it. That's a little teeny koala, by the way, thumb size. Not all Australian animals will kill you. Oh, don't get me wrong. He wants to. He just can't. And that's the right way to think about the tools that we use in practice of medicine, in healthcare delivery. It's exactly the right way. If they really are out to get you, then you're not paranoid. But the right attitude is a certain level of paranoia around the tools that we use. All aspects of care delivery are inherently and significantly dangerous. I sometimes like to, pick on the medical students or residents. Why is imaging dangerous? I'll literally always think of something like the radiation dose perhaps associated with it. Oh, and then why is MRI dangerous? It doesn't have a radiation dose. The real reason is it's false positives. But there's a significant risk associated with false positive results on imaging. For example, you can play the same game with pretty much anything we do right down the line. Well, of course, the root for all of this, November 30th, 1999, Institute of Medicine's Committee on Quality of Healthcare in America. We published a report called "To Err is Human." By this late date, pretty much everybody's heard about it. Of course, the real driver behind it, our soundbite headline, we said that somewhere between 44,000 and 98,000 Americans die each year in hospitals, where the cause of death was not their underlying disease, but the treatments we'd used to address those diseases in a way for each case 2 separate independent expert physician reviewers said was avoidable. Now, when we prepared the report, we did a full evidence review. We found about 60 major articles documenting this unfortunate fact at the time. One of the main reliance articles upon which we relied, the 44,000 preventable deaths per year, is called Utah, Colorado. We threw in a few hospitals from western Colorado to get the sample size up. But that 44,000 number actually came from Utah, just in passing. 98,000, the Harvard Medical Practice Study. In fact, we were replicating that study in Utah to get that range of numbers. So they were the most recent, by far the most rigorous studies done around this topic to that point in time. We knew we were being conservative with that estimate. We didn't want to overestimate it. We wanted to underestimate it, if anything. Now, just in passing, the number I really want to have stick in your mind, I've circled it in red down on the slide right here. That injury rate is associated with 2 to 4% of all patients experiencing at least one care-associated injury during their index hospitalization. So hold on to that 2 to 4% rate in your head. Now, there are 3 main ways that we've ever discovered for finding these injury events, and I've listed them here. By far the most dominant, the technical term for it is voluntary reporting. They're called serious safety events. Nurse incidents reporting. What it involves is someone, nearly always a health professional, but occasionally a family member, a patient themselves, someone else in the care delivery environment, observing an injury event occur. And then they choose to file a report about it. A nurse incidents report, for example. They're also called, as I say, serious safety events, sentinel events, Joint Commission never events is what they're sometimes called. But that's the most common by far. I'd guess that 95, maybe even 98% of all injury detection worldwide happens through voluntary reporting. A far more interesting approach is retrospective chart review, number 2 on the list. With this method, you wait until after discharge, then usually it starts with an expert nurse, reads through the chart looking for any care-associated untoward event based upon chart review. When they find one, nearly always we have 2 separate independent physician reviewers confirm that it's real, is the typical method that's used for that. There's a special form of it called structured review. In structured review, instead of just asking the nurse based upon their own professional experience to find events, you look for very specific instances. The first instance of this happened in Sydney, Australia. A nurse named Bernie Harrison put the system together. Bernie had 28 specific things that she trained her nurse reviewers to examine. So look in the chart, if you see this, then track it to here, then track it to here. And if this all pans out, then you've got an event, if you see the idea. Dave Klassen and a fellow named Roger Rissar from Mayo started with Bernie's list. Now, in fact, mostly they took things already on Bernie's list and separated them into finer categories, but they ended up with 51 in something called the IHI Global Trigger Tool, but it's a way of doing structured chart review, all right? And I've tried to, if you saw the whole slide, distinguish between unstructured review. That's how we did Utah, Colorado, and Harvard Medical Practice Study. We're unstructured review. Then there's structured review technique. Now there's a third, it's called prospective expert review. What you do is use usually electronic tools to watch care delivery patterns, lab values, for example, use of particular drugs, for example. And based upon care delivery patterns, you try to detect where a clinical team is responding to an injury event. And that's a trigger to look back and say, is there a real injury event underneath? For example, if I use naloxone in a hospital, I have to think that this could have been an opioid overdose. Now, there are ways you use opioids in a hospital, well, ways you use naloxone in a hospital that don't mean an overdose, don't mean an injury event. The most common is on the OB service. Turns out naloxone's a pretty good antiemetic. There's emesis, there's nausea associated with epidural blocks. And the OB anesthesiologists fairly routinely use naloxone to counteract that. But they use mini-dose naloxone. So you end up with a set of little trigger rules for review. So if you use naloxone, we really ought to take a look, unless it's on the OB services, the mini-dose, then don't bother, if you see the idea. The guy who really started this heavily was a guy named Scott Evans at LDS Hospital in all the world, is where it started. Stan Postarnik, his colleague, a pharmacist, followed up on it. And they have about 170, maybe 200 of those little rules that they use. Well, the trick is when you start to use structured review, structured chart review, and that prospective expert review, looking at care delivery patterns, your injury detection rates explode up, much higher. This was the first major study of it. Again, the structured chart review tool is called the IHI Global Trigger Tool, mostly because IHI, Don Berwick's group in Boston, funded it. In 2011, we published an article in Health Affairs, a formal gold standard review of a number of these different systems. What it found was that 26% of all inpatients had at least one significant care-associated injury during their index hospitalization. Not 2 to 4%, but 26%. All right? So a dramatic increase in detection rates by using a more effective tool. We then compared it to a number of other systems. For example, the current system that the federal government uses to penalize hospitals for having too high a hospital-acquired condition rate. That tool is a little bit worse than flipping a coin, just in passing. It's called PSIs. Greg Meyer, the guy who developed it when he was at AHRQ, denies he has any association with it every time we bring it up, because it was designed for a completely different set of purposes, but that's what the feds settled on for assessing your performance in your hospitals. But there you go. Interestingly, about 10%, just under 10% of all hospitalizations, the cause of hospitalization was to treat a care-associated injury event in an outpatient setting. David Bates, another famous researcher in the field, just a couple of weeks ago in Annals of Internal Medicine published an article for one of the first. We've never been very good at tracking these in an outpatient setting, but as we expected, we're showing very high injury rates in outpatient medicine as well, primarily adverse drug events. as you might expect. Well, the key takeaways associated with this, yeah, it was validated. IHI Global Trigger Tool, 26% injury rate. Twice, the Office of Inspector General of the Department of Health and Human Services Medicare Medicaid program drew valid random sample of Medicare patients and applied those tools. They came up with 25%. In January of this year, another David Bates article, he calls his approach Safe Care, but it's really the same method underneath. He just didn't use the IHI baseline. He modified it a bit and called it Safe Care, 24% basically. So that's the first main point I wanted you to see. When you improve your detection methods, you get a completely different picture. By the way, using these methods, a guy named John James published it. Never met him, no relative that I know of. He used those sorts of data. He said the real care-associated mortality rate in U.S. hospitals, lower bound, 210,000 preventable deaths per year, upper bound about 400,000. So just put that in perspective. Think about that for a moment. At the peak of the COVID pandemic, we had about 370,000 deaths per year in the United States. So patient safety is roughly on the same scale as the peak of the COVID pandemic in terms of mortality rate, just in passing. With one big difference, COVID mortality rate was for 2 years. This has been year after year, decade after decade in the past and going into the future. Now, this is a little too dramatic, in honest truth. There's some countervailing factors, and you're familiar with them. Number one, on average, current care delivery adds about 3.5 to 7 years of life expectancy to every citizen of the United States. 3.5 to 7 years net of this. The upside is dramatically bigger than the downside. You'd be an idiot, you'd be an absolute fool to stay away from care delivery because of fear of these events. The benefit is so much bigger than the risk. Yeah, you understand it as well as I. You're often walking a very thin line between help and harm. A drug that in the right dose is absolutely life-saving, overdose can be absolutely deadly. And it's sometimes almost physically impossible to avoid stepping over that line, frankly, in all honest truth. Also, the more seriously ill a patient is, that means the more complex their treatment, the probability of one of these happening goes up exponentially as complexity goes up. So the people who are so affected, don't think of them as young, healthy athletes, right? These tend to be elderly folks with lots of comorbid illnesses. Their life expectancy is quite low to begin with. So you're not losing decades of life in most instances, or even years. It's often measured in months or weeks or sometimes just days. If instead of using raw mortality rates, we used life years lost, you get a very different picture along the way, in fairness. You know, it's a funny thing though. I understand an Institute of Medicine report, they're tomes. I mean, I think the Errors Human is 600 pages long. I get it. Nobody reads a full IOM report except us poor dumb suckers who write them and those who review them. The whole second half of that report, though, our main point, we had proven science by which you could dramatically drop those injury rates without losing any of the benefit of our care. That was the point. Frankly, the right goal is zero harm. That's the right goal. I'll have to tell you, in a career in doing this, I don't know how to get there. But I do know you can drop those rates by 60, 70, sometimes even 80%. This is a price we don't have to pay. And that's the key point. If we applied best current science, we can do dramatically better. This is a price, well, that our patients don't have to pay if we were to use those tools. So, key takeaway for this first section, though, it turns out that voluntary reporting, that's the foundation for that 2 to 4% rate, It works very, very poorly indeed. It finds 2 to 4% of patients having at least one care-associated injury. By the way, as the guy who did all the analysis, set up and ran that initial health affairs study, the maximum number we found in any one patient suffered 7 significant care-associated events during a single hospitalization. So they sometimes kind of gang up. What we really learned, though, is that you can't trust voluntary reporting by itself. You have to step forward into those other methods. Most current systems rely on nurse instance reporting, serious sentinel events, never events, those sorts of things. But if you really want to know what your real injury rates are, you've got to drop into those other 2 tools and start to use them. And then you'll be able to see. In its raw, unmanaged state, traditional nurse incidence reporting, traditional voluntary reporting, finds about 1 in 100 of the actual care-associated events. So I'll find about roughly 1% of them. It varies from place to place. Now, sometimes you can really lean in hard on your voluntary reporting, special incentive systems, special training, and then you get up to about 1 in 10. For example, for many years, the British have been running a system, online system, very easy to report, and it probably finds about 1 in 20 to 1 in 50 of the actual events using these sorts of things. But you see the message here. If you really want to find them, you're going to have to use different methods. There's one other deep problem, though, with this. I say 1 in 100. You could get away with that if it were a valid random sample. The trouble is when we've done gold standard head-to-head comparisons, it turns out that voluntary reporting does not give you a clear picture of the actual causes, which is a worse problem. If you rely upon that by itself, you'll spend your whole life trying to fix the wrong things in terms of the impact that you have. So when you get a better detection system, you get very different priorities and patterns and methods out of the thing. Now, frankly, I'm talking to a group of physicians here by and large. This isn't yours so much as it is the hospitals within which you work. This is an institutional question as opposed to an individual physician question. But one of my hopes is by letting the profession know how this works, maybe we can hold our institutions, hospitals, and clinics to account. We can hold them to a higher standard on our behalf, on our patients' behalf. That's the basic idea behind it. Well, why is it important? You can't fix what you can't find. That's why it's really important. If you don't have a good handle on how these things are actually happening, it's hopeless. You won't be able to do anything about it. You'll blithely go on harming people at great expense. So that's why it is so critically important that we upgrade our ability to detect care-associated injuries. So that's the first point. By the way, just in passing, this came out of that initial body of work. It's been validated since. I just wanted to show it to you. This is a list of the actual major sources of care-associated injuries, just to give you a feel for it. Many people haven't seen it before. About 50% of all care-associated injury events are adverse drug events. Overdoses, idiosyncratic reactions, and allergic reactions, drug-drug interactions, those sorts of things. They're about half. Every major study ever done. Roughly half have been adverse drug events. Procedure complications are number 2, not just in the operating theater, but other procedures throughout your facility. Number 3 on the list is very consistently hospital-acquired infection. Chief among those are postoperative wound infections, just in passing. Number 4, pressure injuries that happen during an acute hospital event usually. Number 5, mechanical device failures. That's some more Scott Evans' work. Number 6, complications of central and peripheral venous lines. Some years ago, Primary Children's Hospital, now they didn't count where a child was able to just pull their IV out. That didn't count. It required a minimum local infiltration with tissue damage, a minimum. But some of these can be really nasty if you've followed them. I remember reviewing a case with a surgeon. He had just finished basically taking a vein out from the wrist to the shoulder to try to save an arm from a peripheral IV that had infected, for example. It can be really nasty. Number 7 on the list, venous thromboembolism. You're familiar with that, I'm sure. Number 8, I call strength, agility, and cognition. It's really fall injuries in a hospital setting or use of restraints in some form. So usually with patient mental status being a major element. Number 9, blood products, not just transfusion reactions, but other events associated with transfusion use. And finally, patient transitions. Anytime you move a patient from one location to another and do that handoff. Now, patient transitions, the most common form of a transition-associated injury is an adverse drug event, just in passing. All right? So there's some overlap within the list, but it's a pretty good comprehensive list. It was really funny. Years ago, I was following behind the guy who at that point in time ran the Joint Commission. He'd been kind of outed around wrong surgeries and had focused the entire industry's attention on wrong surgeries. Wait a minute, where are wrong surgeries on my list? It's not there. It turns out, as I pointed out to him in a talk, we were speaking at the same event and I happened to go first. Yeah, I had more than, how to say it, one bad day in Utah on adverse drug events outweighed 5 years of wrong surgery in terms of patient harm. But the advantage that I had is I had a detection system that worked. So I actually knew the rates. So that choice of a target was, to my mind, misapplied. I mean, it's a decent thing to think about, but there are other bigger fish to fry if you're really interested in reducing harm to patients, if you see the idea. Well, anyway, a quick case study to show you what happens when people start to do this well and wisely. Happened in Common Spirit Health System. It had about 40 community-level hospitals, none here in Utah. What they did was automate that structured chart review tool. They used an electronic medical record, and it turns out they could automate initial case finding to say, here are cases that deserve review. They rolled into it that idea of prospective expert triggers like naloxone use, that set of triggers, a subset of them. But they could completely automate it. They had a centralized location where they had, I think it was 4 nurses whose full-time day job was to review these cases and then send them to physician review if they thought they had a real event. Now, it wasn't perfect, primarily because they were using the automated tools. It only found about 20% of patients that had care-associated injuries, which is way better than 4%, if you see the idea, a much more complete picture. And then they just started to feed those data back to the hospitals involved so that the clinicians there could see what was happening. They made it transparent so people could see what was happening. Yeah, it turned out that their injury rates fell by roughly a factor of 2. Depending upon the hospital, it fell from 20% down to one hospital, 60% reduction in injury rates. But it averaged about a 50% reduction in injury rate overall. Far better quality relative to patient safety. One of the nice things they did in this, though, they tracked what it meant to financials, to actual financial performance. This is true in general. Anytime somebody has a care-associated injury, if you don't kill them immediately, it's going to cost more. You end up treating the injury event. And the vast majority, that's exactly what happens. When they die slowly. not quickly. What they discovered is just in terms of length of stay in the hospital, they estimated that they saved about $4,600 per case. Now, interestingly, knowing something about hospital administration, what you have initially during a hospitalization is some very intense, high-resource, critical days, where you use lots of resources. You do most of your most important work early on in a typical hospital stay. So one of the things we sometimes do are operating margins, financial operating margins by day. And on those first few days, you'll have these big, huge operating margins. You're making a lot of money for everything you do in that first day. You're making pretty good money for everything you do in the second day. But the longer the patient's in the hospital, that margin drops day by day. If you have one of these events, it turns out nearly always they go negative. That you're keeping somebody in a hospital bed, but from a pure financial perspective, you're losing money. You don't want to be using that intense hospital-based resource managing these sorts of things if you can possibly avoid it. See the idea? It turns out that if you can reduce your injury rates, it has fairly massive secondary financial gains in terms of your cost of operations. I just wanted to use Common Spirit as an example of that. About 2% of their events were rapid death, by the way, but 98% were just a dark hole sucking down resources. The same is true in a clinic setting. Although it operates by slightly different mechanisms, you could imagine the same thing happening. Why is that important? More and more we're watching the healthcare delivery world shift into various forms of provider at financial risk arrangements. So it's not just the care of our patients, it's not just first do no harm. In the future, this is going to become more and more a critical element of financial survival. This ability, they line up, they work together, if you see that idea playing through. Well, with that, part number 3 that I wanted to quickly address with you. Most people think of these as errors. We have a healthcare delivery system that likes to identify where an injury happened, then point fingers, fix blame, take retribution. That's how the malpractice system's set up, for example. If I possibly can, from a technical level, a scientific level, I want to disabuse you of that notion. It's not the right way to think about it. All right? Another of the major things that we've learned over the years. It comes from a key premise, a fact. Its source is a fellow named James Reason, who wrote a book called Human Error. He's British. Famous book, and it became the foundation for this whole body of science, not just in healthcare, but across many, many different settings. Here's what he said, though. Any time, and I add, highly trained, really smart, fully committed human beings interact with complex systems, mistakes and failures will happen. And that's a well-documented fact. I don't care how smart you are, doctor. I don't care how hardworking, how careful, how well-rested you are. From time to time, it will get you. You got to remember, it is out to get you. And it will. If you practice long enough, you'll probably not have just one, but you'll have a series of them. If you get a good detection system so you can see how they actually happen, that will be sobering. That will be humbling when you see how frequently it really happens. Despite your honest, best efforts by a well-trained, deeply dedicated, extremely careful person who puts patients first. That's the underlying reality. They are out to get you. This system is. All right? It leads to an idea that Reason called human factors engineering. You can study the patterns of the failures, and understanding patterns of failure as well-trained, smart human beings interact with complex systems you can start to design those systems to anticipate the failure modes. And that tends to greatly reduce failure rates, injury rates. So that's how you approach it. One of the worst things you can do is to fix blame. All right? Even if in some cases somebody is to blame, there's a system that we have to assign culpability, but you will do dramatically better to focus on the good people doing their level best, well-trained, well-respected, to focus in that area than to put your primary efforts after those who really shouldn't be there. You got to deal with them too, let's be honest. But your primary effort should be around this principle, all right? What that really means is that you're trying to make it easier to do it right. The key principle is, how might you make it easier to do it right? How do you design a support system that helps those at the sharp end who are doing the hard stuff, going at risk with their patients? How do you help them to track that narrow path to success, you see? Reason gave us 3 different ways in which humans interacting with systems do fail. Now, technically, let me be fair, they're all errors. By Reason's technical definition, they're all errors. The trouble is his definition of errors is so radically different from what any one of us intuitively think of as an error, where somebody screwed up. All right? 3 ways that we fail, though. They're called skill-based performance, rule-based performance, and knowledge-based performance. They're the 3. What Reason called his generic error modeling system. Skill-based performance? Well, you have a pattern that exists in your brain. It's developed through practice and repetition. Think autopilot. Okay? Driving a car, doing the dishes. Interestingly, when you're in that mode, when the human mind is in that mode, not just in healthcare, but in any setting, you'll get about 1 to 3 failures for every 1,000 opportunities for failure. So it has a 0.1% to a 0.3% failure rate. And interestingly, this last bit's fairly important. You will detect and correct your own skill-based failures about 60% of the time before a real failure occurs. So you start with that 0.1 to 0.3%, then reduce them further by 60% because we'll catch them and correct them on our own. Okay? Yeah, just some examples of them. He divided them into what he calls slips and lapses. Slips, an act performed, wrong, errors of commission, misspelling a word on a slide. I have some slides that I use when teaching at the university or with residents that I've been using literally for 20 years. And I still find occasionally spelling errors on them that I've managed to overlook across hundreds of uses of them. It's amazing. Classic slip. Lapses, an act not performed when required, an error of omission. So you failed to do something that you really should have along the way. So a nurse delivers a dose of a medication late. Would be one good example of that. And there are many, many different examples of these slips and lapses. Well, the big dog is going to turn out to be rule-based systems. Rules are routine, actionable knowledge of how the world works. So here's some common rules. Oil and water don't mix. There you go. What goes up must come down, at least if you're in a gravitational field, without an active force being applied. While driving, always signal and check before doing a lane change. Now, there's one. I'm going to find some failures. Almost certainly. Yeah. The reason this is important, we'll see the numbers about them in a minute. I'm going to share numbers around them. They take the form of policies, procedures, mandatory safe practices within a care delivery setting is the form that they take. And we need to come back to this one because this is going to be the really heavy lift along the way. So rule-based performance, how does it work? The brain perceives a situation. You scan for a rule. Hopefully you get the right one. Then you act to apply the rule. okay? And when it screws up 3 different ways. Sometimes we just grab the wrong rule. Okay? I guess that's really number 2. Misselected a correct rule, wrong rule, the accepted rule is simply wrong. Did Columbus really discover America in terms of Europeans? Debatable. You see the idea? You misselect a correct rule, so there's a little game you can play. I would ask you, please out loud spell most, spell coast, spell boast. What do you put in a toaster? And it's interesting, about 90% of the group will say toast. And the right answer is no. No, you put bread in the toaster and you get toast out, right? And what your brain is doing subconsciously is misapplying the spelling rule, interestingly enough. Now, occasionally somebody has the rule, just decide not to follow it. Now, why is it important? It fails about 1 out of every 100 opportunities it fails. So it's more than a 10-fold higher failure rate than skills-based performance. We're still, with skills-based performance, I'll find and correct them about 60% of the time. With rules-based performance, it drops to 20% of the time. And we're going to pull those numbers together in just a minute. So the trouble is, another element, there's a limit to how many rules a human being can hold in their head and correctly apply. The human mind does not have infinite capacity. The best estimates we have of these, I've never seen a formal study, it's how many drugs physicians put on their pick lists in the electronic medical record. And it appears that among, well over 700 drug classes that you should know, most physicians use about 60 to 100 drugs. And it has to do with the carrying capacity of the mind. Interestingly enough, it's about 60 to 100. In a hospital, though, we used to call them nursing policy manuals. I remember reviewing a case at Primary Children's Hospital. A child, a 14-month-old child, brought in for placement of a hydrocephalic shunt. She had other congenital anomalies. It turns out that the fellow assigned to the case, a neurosurgery fellow, he was brand new at primary. It was his first rotation on a pediatric service. He was already boarded in general surgery before he went into his neurosurgery residency. He was one of the best fellows they'd ever had, they claimed. Well, it turns out that Primary Children's had a rule in their policy manual that when giving digoxin to a child, that the physician was to calculate in writing on the order sheet a weight-based calculation of how much dig to give this child. The rule then said that the patient's nurse, lead nurse, was to complete a parallel calculation independently, and the two had to arrive at the same number. If that failed to occur, the ward clerk, the unit coordinator, was to refuse to take the order off the order sheet, and pharmacy was to refuse to fill it. Well, what happened in this case is this new neurosurgery fellow, he didn't do the calculation. He looked at the little bottle of Digilixir, and he misplaced a decimal point. And he gave a 10 times overdose, is what he ordered. There was no weight-based calculation. The nurse did no calculation either. The unit coordinator did take it off and send it to pharmacy. When the pharmacy got it, they scratched their head and said, this is too high a dose to put into an elixir. Of course, at a children's hospital, you sometimes have very close to adult patients, 16, 17, 18-year-olds. He sent up adult-sized pills. The patient's nurse looked at the pills and said, how do I get this into a 14-month-old? Actually checked to make sure that she could grind it up in a pestle, put it into a sugar solution to get it into the kid. All right? And of course, her cardiac condition destabilized to the point where they scrubbed surgery the next day. 3 days later, when she was on the point of death, they figured out they were giving her a 10 times overdose of digoxin. Classic adverse drug event. What do you suppose our response was? What did the hospital do? Yeah, I wrote a letter of condemnation and put it in the residence file, in the fellows file. Blame, because they had a rule. And so I had a couple of obvious questions. How many rules do you have, guys? About 1,600. Wait a minute, 1,600 is way beyond the carrying capacity of any human mind. Question number 2, you have not just fellows, you have residents, you have medical students, you have nursing students, nurses, you have attending physicians rotating through your care delivery environment. How do you train them all? Did you train that fellow in your 1,600 rules? What do you suppose the answer was? No, of course not. That's silly. We could not begin to. Now, do you see the problem with rules? Number 1, we have way too many of them. Number 2, we don't have an effective method for deploying them. The nurses hate it when I say this, but this is true. They claim that they do have utility. The only way I have ever seen them used is to sue a physician or sue a hospital, because it's de facto malpractice by the way that's set up. So it's going to turn out to be your mainstay tool, but there are a limited number of things that really matter. Otherwise, it becomes so top-heavy and unmanageable that nobody can use it. How do you pick the ones that count? Number 2, how do you test them against reality to make sure that each rule actually works? If you see the idea. Number 3, the big one, how do I make it easy to do it right? How do I build it into workflow so that it doesn't rely on memory? So the system responds in support of the clinician at the moment in time when they need the help. We've just, if we're thinking that way, now we're doing human factors engineering, if you see the idea. Yeah, and then of course you have to have some way of regularly reviewing and updating. Think of your own clinical practice environment, inpatient or outpatient. What do you have in place to support you at this level? It doesn't happen at an individual physician level, it always happens at an organization level. What do you have in place in your practice environment to help you with these sorts of challenges? Is what the question becomes. That's what you must have if you're going to deliver safe, effective care. That's what you have to demand, is that level of support, if you really want safe and effective care. Oh, I realize sometimes you're going to find an outlier physician or nurse who really shouldn't be there. And of course we're going to react appropriately when we find one and get them out. But this will account for 99% of all of your care-associated injuries, these sorts of things right here. So, knowledge-based performance, this is category number 3. Turns out this is special circumstances where we don't have any rules. Or the rules are completely unknown to those who are charged with taking action, all right? Tends to be associated with very complex problems where we're thinking slow, according to Kahneman. We're trying to work it out on the fly. People working outside their areas of training and expertise, trying to figure it out, basically, as you work. Their lack of knowledge errors, sometimes called errors of planning, and holy cow, they're messy. 3 to 6 failures for every 10 opportunities. They have a 30 to 60% failure rate. And our ability to detect and correct is the lowest of all, 10%. Happily, they don't happen very often. When you actually stack it up with empiric data, this is what you get. If you look at actual injury rates, about 5% of all injuries are skill-based injuries. Of those well-recognized slips and lapses, you know you're going to do it. Doesn't matter how hard you try. Rule-based is the big guy. So that's the one where you can get the highest leverage. Knowledge-based, it's about, well, 27% is what Reason said. So important, but much more difficult to approach, where you're working outside of current established science. Hopefully in that setting, you're doing it in such a way that you can learn from it for the next case, because you're exploring the boundaries of our shared knowledge. Is what that really means in that circumstance. Now, there is one other idea that I wanted to share with you relative to this and how you make care safe. It's called the culture of safety, and I try to illustrate it here. Some of the things we're talking about, for example, there are systems to reduce adverse drug events. And to err as human, the major example we used came from LDS Hospital. And it had to do with the system to reduce injuries associated with adverse drug events. It reduced them by 62%. What it did was help with dosing for every dose of every drug on a computerized system that John Burke's group put together, and it was a wonderful success. Really took the injury rate down by providing better support to the physicians and nurses who are delivering the care, making it easier to do it right. Well, that's great for adverse drug events, post-op wound infection, so on down the list. This is a rough layout of that list of common sources of injuries I showed you before. Culture of safety is something that cuts across all of them, and it's mostly about how we think, so attitudes and approaches or policies about how we think about this problem. So it's an appropriate way to kind of begin to wrap up when you're talking about patient safety. Ken Kaiser, way overeducated. He's boarded in 4 medical subspecialties, by the way. He's the guy who reformed the VA years ago, very, very successfully. Interesting man, currently at UC Davis, just in passing. He described a culture of safety, well, let's just read it, an integrated pattern of individual and organizational behavior based upon shared beliefs and values that continuously seeks to minimize patient harm, which may result from the processes of care delivery. It's interesting. Do you notice in that thing that he talks about patient harm, but he doesn't point it at physicians and nurses? He points it at the processes of care delivery. He's got it right. You see that idea? Yeah. Now, you have these in the handouts. They're probably too small to read right here, but I want to run through them very quickly. First of all, it's shared beliefs and values, a shared recognition by all members of a care delivery organization, not just the clinicians, but particularly administration. All right? That are regularly and forcefully reinforced, both at a professional level and at an organizational level, that number one, healthcare is highly complex, innately error-prone, and that's a high-risk undertaking. The tools we use are innately, inherently dangerous. Everything we do has the potential for danger. It's just the nature of our work. That's what we signed up for. In that setting, failures are inevitable, Ken says. Anytime you have humans in complex systems, you're going to get failures. But those hazards and errors can be anticipated. And that means that you can begin to design care delivery processes that anticipate failure modes and make it much easier for your clinicians to perform at a higher level if you design the processes correctly. What have we done, though? We've just bumped it from the level of an individual physician or an individual nurse up to the level of the group. That's what this has just done. To have safe care, it demands that you function at that group level. It's the only place safe care ever really happens. Not that our own commitment isn't important, it's critical, but given the complexity of today's world, that's where you have to be able to function. Number two, patient safety competence. You understand that knowledge and skills form an essential foundation for safe practices. The competence is ephemeral, and therefore it must be actively maintained, and frankly, current health professional training does a really poor job of training us in it. So it belongs to the actual care delivery groups down the line. Number three, measurement. We've already talked about that at some length. You have to use measurement systems that can actually transparently show what's really happening. You need to be thinking in terms of structured chart reviews and those active concurrent clinical trigger tools to get a real pattern of what's happening within your organization. Number four, response. organizational structure that allows you to use those data to prioritize and identify opportunities for better, target them, act against them, and show that it got better. So that you have data showing that, yeah, you have created a better, safer environment. Verify the actions taken, their effectiveness, whether there were any untoward secondary effects. And number 5 is in some ways the most interesting, communications. It starts when leadership sets clear expectations, but you start to be completely honest inside and outside the organization about these things. You do not hide them. There's an interesting secondary literature that I haven't touched on here that shows that when you start to level with patients, they understand that healthcare is dangerous. They understand that nobody's perfect. And if you set it up that way, malpractice risk tends to drop by about 25 to 50%. And you end up, instead of giving the money to the lawyers, you end up giving the resources to the patients with need. That's a discussion for another day. Started in the Lexington, Kentucky VA, and then started to move across the profession. A number of groups have used that very, very successfully to, number 1, reduce their malpractice expense. They'll have lots more events they detect, but when they go tell the patients, even if the patient hadn't figured it out, and then they focus their resources to make the patient whole. One of the real criticisms of the current malpractice system, it's not what it does to the medical profession, it's what it does to patients, for heaven's sakes. About 60 to 75 cents on the dollar of all money that goes into malpractice goes to feed the legal system. Only about 25 to 40 cents on the dollar ever makes it to a patient, with a lag of about 7 years for patients in need. And it's an organizational priority within your organization to get this thing set up correctly. Well, the idea of a culture of safety. With that, I just wanted to close with one fun thing. I thought I had a slide for it, but I guess I didn't. It happened at a big national meeting at the Institute of Medicine. Old friend Don Berwick and I were on a panel with Kathleen Sebelius, who at the time was the Secretary of HHS in the Obama administration. And they were talking about patient safety. Oh, by that point, we were 12 or 14 years into it. And we had some fairly spectacular examples of care becoming much safer for our patients. We'd actually made it work. Now, at the same time, our detection systems were getting better, so you had these kind of dueling realities. It was actually getting safer, but we were finding them better, and it's hard to tell where the mix comes out in terms of baseline. The trouble was is that Secretary Sebelius and Dr. Berwick were talking about this in terms of error, human error, blame. So I asked Don a question. I said, Don, you and I have been in this since the start. We've got some really good successes. The IHI 100,000 Lives campaign, for example. What Peter Pronovost did in terms of central line infections in ICUs, his famous trial up in Wisconsin, for example. The stuff that we'd seen out of LDS Hospital around adverse drug events and around deep post-op wound infections, famous articles in major journals, right? We've got these successes. Well, Don, thinking about all of our successes, here's my question. What proportion of them came by identifying and punishing physicians versus what proportion of them came by understanding patterns of failure and designing safer systems to make it easy to do it right? And the short answer is, guys, 100% of all advances in patient safety have come at the level of human factors engineering. Getting good enough data to understand what happens when smart, dedicated, very highly trained people interact with complex systems, understanding those patterns, then designing those systems to anticipate failure modes and make it easy to do it right, 100%, if you see the idea. This is about how we support each other so we can be the best we can possibly be. On this one, the sky's still the limit. Huge upside for this one. We could be dramatically better. Oh, by the way, when you do, your internal operations will really improve. it'll have secondary financial impacts, just in passing. You know, when you think about something like this, it becomes almost a professional call, doesn't it? A call for the profession to step up to the line around our core shared commitments about what it means to be a physician, about the commitments we make as we enter these professions and the services we deliver to our patients. Well, with that, I hope this has been at least somewhat entertaining. Perhaps you've learned something you haven't heard before. The science is there for those who can reach forth and grasp it. And with that, I'll say thanks for your time and attention. I've quite wisely left only about 1 minute for questions, you know. Does this provoke any particular needs or ideas? Did I get anything wrong?
Thank you. Always good to see you. Yes. Well, thank you all for joining us today. We have more exciting adventures tomorrow. Again, you can be educated down at the movie theater tonight or something. And tomorrow morning we'll start again at, do we start at 7? Start at 7. Don't stay up too late. And thank you again, Dr. James.